We were doing a balloon expandable valve procedure, and the balloon ruptured during inflation of the valve on a piece of calcium in the annulus. And so we had to withdraw the system because the valve was partially inflated, but not able to be fully inflated. We were kind of stuck.
Hey, CathMasters, welcome back to the Percutaneous Axillary Access Series. This is Amit Goyal, and I am back with Drs. Li Peng, Nazli Okumus, and Raj Tayal. In the last two episodes, we discussed data-to-delivery and Raj's own Proctor Playbook for state-of-the-art technique for access and closure. But not every case goes as planned. Like my friend Dr. Tony Beery likes to say about interventional cardiology, it's a minefield. In this crisis control episode, let's talk through bailout for a feared complication. Lee?
We are ready for dry closure after percutaneous axillary access TAVR using right axillary artery. For this 8 mm artery, we have an 8x40 balloon positioned proximal to our access point. After removing the guide catheter, our first Perclose snapped and second Perclose seemed to tie down fine, but angiogram after balloon deflation showed wide open extravasation. We go back up on the balloon at 4 atmosphere. We still have our wire access through our axillary arteriotomy. What are your initial steps before pulling out a cover stent?
This is a very common scenario, unfortunately. But since you still have a wire into the artery, I mean, you can really pick whatever you want to do, whether that's going in and deploying another Perclose, simply rotate it. That again allows you to maintain wire access. We had talked before about our methodology in terms of advancing the dry field balloon to the arteriotomy site, holding it up for 5 minutes, deflating it, reassessing, doing it again for 5 minutes, reassessing, and then ultimately giving protamine and doing it for 5 minutes and reassessing. Alternatively, I think commonly you are really able to get pretty good hemostasis also utilizing an AngioSeal. Collagen-based plugs have kind of been frowned upon in a number of scenarios because you do lose wire access. But since you have the 018 wire up and across from the leg or alternative access point, you can always bail yourself out with a balloon or a stent if needed. There have been some scenarios where we've had patients have devices put in without any closure, or we've had both Percloses snap, or one of our friends has kind of been trying to make a nick at the arteriotomy site and they accidentally cut through both of the Percloses. If that happens and you still have wire access, what I would tell you to do is basically reinsert a larger sheath. So again, whether that's 12, 14 French sheath, put 2 035 wires in place, take the sheath out with 2 wires in place, and then you're basically going to insert 2 8 French sheaths side by side. From there, you can basically sequentially deploy Percloses in order to have what we call post-closure. You still have wire access with the second one. So again, if there's still ongoing bleeding, you can then pivot to either a third Perclose or AngioSeal, as we talked about before.
Those are excellent points, Raj. I have a follow-up question. So when you mentioned give protamine with the balloon inside the body performing balloon tamponade, is there any concerns for thrombosis?
I mean, I think you would have a higher risk of doing that in the coronaries where you're talking about 3 mm, 4 mm vessels. Usually in the periphery and the axillary artery, when you're talking about 8, 10 millimeter arteries with the balloons being up for a matter of minutes, I've never seen it happen clinically. We've done a number of these cases. So thankfully, no, we haven't really seen it. Theoretically, could it occur? The answer is sure. Could you give half dose protamine? Sure. I think that depends on your own willingness to kind of believe in this or not. But I will tell you that, again, when you do this, usually by the second cycle, in almost every instance, it's totally gone. It works in the femoral artery. It works beautifully in the axillary artery. So, when you look back, you'll be amazed at where you can get yourself out of just with internal balloon tamponade and external pressure.
Raj, after 3 or 4 cycles of balloon tamponade, we just do not have hemostasis, and you're concerned that maybe there is a small tear in the artery that's just not going to be amenable. So we're thinking about a covered stent, and probably for a variety of reasons, the self-expanding Viabahn platform is better than a balloon expandable covered stents for better apposition, crush resistance, and this especially mobile location. And of course, we have to think about the branch vessels, especially the vertebral and internal mammary arteries. In thinking through this, Raj, what sizes do you keep on shelf, for a lab that wants to get more involved with percutaneous axillary access? And How do you deliver these? And are there any long-term implications of coverage of the axillary artery? And I recall earlier, at least in the data-to-delivery episode, you said that these are pretty well tolerated long-term.
Yeah, absolutely. So it really depends on where your bailout wire or your secondary access is. So from the femoral artery, you can usually get bigger things in. It's important to recognize that there are size limitations when it comes to Viabahn. But basically, with the Viabahn system, you can go up to an 8 mm stent via the radial artery if you use a 6-7 slender sheath. Anything above that, you'll have to get a larger sheath in. So whether that's defaulting to brachial access, which I absolutely would advise everyone to try to avoid if possible, would be your next alternative, or getting a larger sheath into the groin, taking a destination sheath or a peripheral sheath up may help you get a larger device in, but understanding what the size limitations and requirements are of these stents is important. So typically speaking, I think right off the bat, I always have a 7 and an 8 available. I think in 1 or 2 instances, I've seen a 9 utilized. You can technically balloon these a little bit, but as you know, they're pretty much what you get. So you always want to be slightly oversized. I think we had mentioned previously that the average diameter of the vessel for most patients is somewhere around 6 to 6.5 millimeters. That's where I'm saying the 7 to 8 millimeter Viabahn typically covers most of these, assuming that you're in the second portion of the artery. There really are no major branches that you are going to occlude in the second portion of the arteries that are going to be that meaningful. So if you occlude or obscure the lateral thoracic, that's fine. The subscapular is a little less desirable as long as you don't occlude the suprascapular artery, which is much more proximal in the first portion of the artery. You should be fine with very little to almost no long-term sequelae for the patient.
Can you share your experience when you use radial access for stent delivery in terms of the length of the radial sheath you would choose, and in terms of the radial sheath size, how they are able to accommodate the stent delivery?
Yeah, so I would just use a standard, 6-7 slender radial sheath by Terumo or whatever company your cath lab has that can accommodate up to a 7 French system. The trick here with the radial artery is it will be very difficult to visualize where you're going to be able to deploy the stent. And so when you're doing this just over a wire, one of the important things we had talked about before was kind of demarcating where the needle hits the artery, where your percloses are in the artery, and where the site of bleeding is based on an angiogram. So if there is bleeding and you've taken a picture to identify where the bleeding is coming from, what I would recommend doing is taking vascular markers, marking it on the screen, locking the table, locking the position, not moving anything, and then basically deploying the stent based on where those markings are. Because when you're doing this, it's not like you're going to have a destination sheath in a lot of instances, because you're exchanging your dry field balloon out over the 018 wire and then advancing a Viabahn directly. And that's part of the reason I'd suggest for the first 5 to 10 cases that you do, it's easier and much better to have femoral access, because when you inject contrast, when you're taking pictures, you're doing it antegrade. So you can see things much, much better, even further down the artery. When you're taking a picture from the ipsilateral radial and you're injecting retrograde, number one, it's hard to opacify the vessel. It's hard to identify the exact location of bleeding. So just keep that in mind.
These are very helpful points. Despite balloon inflations, we are unable to achieve hemostasis, and now we are committed to covered stent. Can you please walk us through the step-by-step of placing, positioning, deploying, and post-dilating a covered stent from the point of having our tamponade balloon inflated from the radial artery and our wire across the axillary arteriotomy?
Of course. So again, we're going to take a picture, right? So we have our balloon and we've ballooned the arteriotomy and it's still bleeding a lot. And so you're going to have one of your colleagues holding pressure. You're going to take a picture to identify the exact source and spot of bleeding, right? So if the artery is torn, the bleeding can occur distally. It can occur a little bit more proximally to the access point. So it's important to make sure that you're positive where it is. I would really recommend using vascular markers if you're coming from the radial artery, as opposed to trying to get a destination sheath up and taking pictures while you're deploying the stent. And then basically deploying the stent, you're going to upsize the stent, the covered stent, by 1 millimeter on average, if not more, than the size of the artery. If you have the luxury of having a pre-procedural CTA, again, you take a lot of the guesswork out of this. I will say, again, we had mentioned that arm positioning plays a role. So if patients' arms are, above their head during the CT angiogram, sometimes the arteries can be underestimated in terms of their size, although not frequently. But I would say that these stents, it's better to be oversized as opposed to undersized, because to your point, post-dilatation is not necessarily always ideal in these scenarios. When you take a self-expanding stent and you post-dilate it beyond the size it's intended to be, it will foreshorten. And so, having a little bit of extra length here is not always a bad thing. I've seen people try to get too specific and putting it directly where they think it needs to be, and then ending up with a series of needing a bigger stent proximally or needing another stent distally. So, taking the 50 millimeter covered stent and just kind of being in an area and being in that second portion of the artery are all very fundamentally important, because you can do this very, very quickly with almost no blood loss. And that kind of goes back to the point where we talked about how can you have more minor vascular complications, but less bleeding events. And this is exactly why that is.
In your experience, are there situations when a covered stent either not feasible or not effective? And when do we get vascular surgery involved?
There has been one instance where we were doing a balloon expandable valve procedure, and the balloon ruptured during inflation of the valve on a piece of calcium in the annulus. And so we had to withdraw the system because the valve was partially inflated, but not able to be fully inflated. We were kind of stuck. So again, what we did is basically we were able to pull the device back into the artery. We inflated a balloon proximal to stop bleeding. And that gave us enough time for a vascular surgeon to cut down and then extract the device, and then basically put a conduit on so we could go back through the artery, put the TAVR valve in, and then come out successfully. But again, if you're in the second portion of the artery, you, number one, should have the ability to control the vessel proximally without a lot of risk and or ongoing bleeding, and give your colleagues enough time to get involved. So really having a conversation with, a colleague, I think ahead of your procedure, walking them through your steps, your thought processes, the data, sharing this with them, I think is important, because nobody likes to be ostracized or targeted after something like this. There is a plethora of data to suggest this is safe, that it's reasonable, and that it's still a much better alternative than any form of surgical intrathoracic access. So for anyone skeptical, I think that you guys have done a great job in terms of listing a lot of the references behind this technique, some of the safety points. And I think after highlighting and understanding the watch-outs and the bailout mechanisms, most people should be able to do this with less than a 2 to 3% failure rate.
Wow, this has been so amazing. Across these 3 episodes, we discussed the really a robust evidence base in the Data-to-Delivery episode about safety and efficacy, and I think enough to convince even some skeptics. We, in the Proctor Playbook, heard not just the recommended approach that's been published, but also, Raj, we got to hear a lot of your personal tips and tricks and caveats that really elevate this discussion. And for the crisis control, we learned how to manage some of the complications. I truly believe that most people can do most procedures very well, but it's really how one manages complications and approaches them in the moment that differentiate the skilled operators. So thanks for helping us get there. Raj, this has been just so incredible to hear, and I am excited to put this into practice. Thank you for your time.
Thank you guys for having me again. If I can answer any questions, you guys are always welcome to reach out to me directly. I'm always here and happy to be a resource in any shape or form I can be.
I've done a few axillary access, but I just feel like I learned so much through this discussion with you, Raj.